Thank you for joining XROM, India's first AR/VR focused podcast today. I'm delighted and honored to have with me Dr. Rohan Jotwani, who's an M.D., M.B.A. anesthesiologist and pain medicine specialist, Oxpine at New York-Presbyterian Weill Cornell Medical Center, and co-director of the Extended Reality Anesthesiology Immersion Lab at Weill Cornell Medicine. The podcast conversation is going to be about XR and AI revolutionizing healthcare. So, Doctor, really appreciate you taking time in being part of the podcast. Technologies which is converging. There's not a single industry where tech is not touching. So how is healthcare being impacted with technology?
I think healthcare and technology sort of go hand in hand, right? When we think about how we've been able to expand human life and give people quality of life and length of life, how we've, combated diseases from polio all the way to COVID, all these things require a deep understanding of new technologies. And healthcare, which is an industry where we have to be very cautious about technology. We don't want to, Zuckerberg and many folks who, create startups in Silicon Valley are very famous for their concept of, move fast and break things. Here, the things, would be people. So we have to be exceedingly cautious about how we integrate technology. We have to always sort of keep in mind that, the technology that we use in healthcare almost always interfaces or affects patients in their lives. But we would not have made much progress in terms of health had we not discovered things like vaccines, had we not discovered things like the use of the first anesthetics to make surgery possible. So healthcare and technology have always been intertwined from the get-go. It's now that we've started to incorporate technologies like the use of computers, whether you think of something simple like how we keep records. So a big move that we've seen in the United States over the past few decades is to take records that normally existed on paper and turn them into something that we can access through these very large networks, through these very large electronic health records. And how we've been able to use that big data to improve healthcare for the masses. We have also integrated things like robotics into perioperative medicine. So now a lot of surgeries that used to be done with hands are now done through robots. And we see that sometimes improves the ability of the surgeon to do more precise care. And I guess in the latest iteration of how we seem to be incorporating technology into healthcare comes through the form of things like extended reality and artificial intelligence. So it's a path we've been on for centuries, but it's really getting exciting now as we think about all these new technologies coming out of places like India, places like Silicon Valley being incorporated into everyday practice.
So you were mentioning about, the digitization of data. Are the data siloed, or do you see data being more decentralized? Because I guess that's when, the real value gets added. You mentioned about extended reality and AI. Can you give some examples on how you are leveraging XR+AI?
Yeah, sure. So when it comes to just sort of the broad concept, right? Like, have we been very good about decentralizing data in the United States in healthcare? The answer is probably not great. We have a huge regulatory framework where we want to protect patients' privacy. So all the data that we collect in our networks have to go through a lot of regulatory issues before we're able to distribute them to third parties to be able to sort of gain value from that data. And for a long time, a lot of the healthcare electronic records that we use were fairly siloed. So companies that were building these electronic health records didn't make it easy for other healthcare companies to access that data. So, for example, here in New York City, we don't have just one hospital, New York-Presbyterian, we have many hospitals. And sometimes even today, a patient will come to me who's had, say, an MRI done at another hospital, and I can't see that MRI. And that MRI exists in the cloud, but the services just don't talk to each other. So we still have ways to go before we make that data truly accessible, across the country, but we're making progress there. I think to your second question, how are we thinking about incorporating things like extended reality and artificial intelligence? into healthcare, I think of it in two big buckets. The first big bucket is how we're using extended reality to make healthcare professionals like physicians better at their jobs, right? So extended reality is a playground for us to reimagine how we train doctors, nurses, allied health professionals, really everyone, and how we, allow for physicians to have better insight into, things like, say, surgical planning, and how we do things like train people across the world on very new procedures. So that's one bucket of how we use extended reality to make us better. And the other bucket is using extended reality as the therapy itself to take care of patients. So, as we're learning more about how things like mobile apps can help track patient outcomes and improve patient behaviors, the immersion and digitization of, spatial computing through the headsets has opened up a new avenue for us to be able to actually deliver the treatment to patients. As a pain doctor, this is very interesting to me because one of the major use cases in extended reality digital health therapies is for pain management. And we find that we're able to not only train patients better on how to perceive pain, but we can also distract them during episodes of acute pain and hopefully even perform physical therapy through the headset. And so this has opened up an entirely new window of therapies that we didn't think was possible. And we learn more and more every single day.
Yeah, how cool is that? Because I think the healthcare industry is completely upending, and I hope that the data gets more open sourced because you can innovate better when the data is shared with everyone. And I guess then there'll be more hands which join in together and possibly find ways to create better innovations in the healthcare ecosystem. And like you mentioned, the mobiles itself are becoming such a source, playing an important role in healthcare. I was just reading a couple of days back, there's this mobile AI app which you kind of use your camera, you scan your tongue, and it kind of predicts a certain kind of bunch of disease that you might have basis on the scan. So I think, yes, AI, XR, and all these technologies are converging. And I think, when you start leveraging it, I mean, there is so much of awesomeness over there. I want to go step by step. You mentioned of healthcare professionals in training in surgical procedures. So can you expand on that and maybe elaborate on some of those maybe training? Do you kind of develop the XR content in-house, and how does it work? When you're talking about these training for healthcare professionals.
Sure. Yeah. I mean, I can start by just telling you how I got interested in the space. So, years ago, I was an anesthesiology resident, and I made a choice. I said, okay, I want to learn how to do interventional pain medicine. And a lot of interventional pain medicine is based on this idea that, there are parts of the body that serve as the etiology for someone's pain. And, whether it's a herniated disc in your back or a nerve that's entrapped in a part of the body, one traditional way would be to open the body up and take care of it. But, that has a lot of morbidity associated with it, and it can be a sort of big surgery. The whole sort of function of interventional pain medicine has been to figure out how we treat that patient minimally invasively. So, if sometimes making a surgical incision is the last approach, maybe we can bring a needle there, right? Maybe we can use image guiding like ultrasound or an X-ray machine to very targeted bring, a small, tiny bit of medication to the part of the body that needs it the most. And that takes a lot of training to be able to do. So there are a lot of procedures that we have where the margin of error can be millimeters. And so when I started my interventional pain training, you learn about all these procedures. I mean, you name a nerve in the human body, and we probably have a nerve block to target it. And you're expected to learn all of this in 1 year, So for us, it can be daunting. both as a learner and then now as somebody who teaches fellows and residents, it can be daunting to try and get through that process. And every year we learn more procedures. There's not a day that goes by that I don't read somebody's doing something interesting. And so when I first started down this journey, the way that I was taught was through PowerPoint lectures, through videos, and then through guidance during the procedures themselves. But there had to be a middle ground. There had to be a way to actually practice doing what we were hoping to do on a patient before we actually did it. That also brings into an interesting point that not all patients are exactly the same. So the things that you read about in the textbook may not apply to a patient who's had a complex surgery or has cancer where the anatomy is very distorted. So I actually started my journey because I saw online that there was a software where you could project holograms of the human body and you could turn them into 1,000-foot structures, and you could literally crawl through the human body like an ant. And I said, wow, like I'd never heard of this. I'd gone through medical school, through residency. No one had ever shown me that this was possible. I bought a headset myself. I downloaded the software myself, and I just started experimenting. And in that sandbox, I realized I was getting better. I was making connections about human anatomy, about approaches, about angulation that would otherwise take me weeks to make. Like my mind was working in a way that just wasn't possible watching a video or looking at 2D pictures. And so I started to bring the headset into clinic. And whenever we would have medical students or residents who were watching the procedures, I would say, okay, let's show you exactly about what we're about to do before we do it. And they were also I could see the light bulbs going off. And that's when we knew we had something. So the question was, how do you create a real pedagogy out of this, right? Because it's one thing for a single user to be in a headset by themselves and making these connections together. It's a completely different thing to think of the virtual environment as the classroom, right? Where you have teachers and learners coming together. You have to plan lessons. None of this, Eddie, existed. We're still trying to figure out what is this form of pedagogy. It's like trying to revamp the classroom at its most core foundation. Like simple questions like, how do you teach in virtual reality are questions that we came across. And we started creating lessons and we started bringing multiple people into these rooms. I started to think about what tools do you need to really teach well in these spaces? So we started to reimagine how we do medical education, how we train people to take care of patients. Along the way, we also learned some really exciting things, which was the models could get as complicated as you needed them to be. And one thing I became very interested in is, could we make models of the patients we were about to take care of before we took care of them, right? Could we really see this through, in healthcare, we have this concept called point of care. So say you show up to a clinic and you need a service provided, we need to check your blood sugar. In the old days, we'd take blood, we'd send it out to a lab, we'd get the results, hopefully in a day or two. Today, we have a lot of what we call point of care technologies, where the machine exists in front of you and you're able to deliver that care almost immediately. And we find that whether it's in the operating room or in the clinic, point of care technologies really do improve the quality of care that we can provide. I had this idea that why not make XR point of care? One of the things I had seen in the industry was when medical schools or residency programs incorporate XR, it functions as a form of simulation training. So it exists within this bucket of, a sim lab. And my opinion was, why? The training that people need is at the moment that they need it. One of the flaws that we see in simulation is that it's wildly expensive. You have to build these $1 million centers full of technology, and you have to hire people to run those centers, and you have to keep the lights on. The second thing is it's really hard to get the residents and the medical students to that center. So, residency, just like it is in India, here in the United States, is functionally a job. It's a job where you are both training and learning, but it's also like you have direct patient care responsibilities. It's very expensive, costly, and difficult for the system for me to tell the residents every day, hey, you need to take an hour to come to the sim center, because that's an hour away from patients. Somebody has to be taking care of those patients when those residents aren't there. So the direct and indirect costs are astronomical, especially at a time where we don't have enough healthcare employees to take care of everyone as it is. The great thing about XR is it brings the sim lab to the situation that you need it to be in, right? I don't need to ask for hours of people's time. We can pull it off in 5 minutes if we need to. And that kind of thinking is what I think allows us to train people in real time in the way that they need that training.
So, Doctor, you mentioned about, besides the training, the therapy, pain management, it can be, pain itself is very, very, very draining, and with these VR, I've seen these, I think Ritchie's plank walk, and that's one reference.
Sure.
It's this plank which is on the top of a terrace.
Oh, I've done Ritchie's plank walk. Yes.
Yes. So it kind of tricks your motor cortex into kind of believing that you are actually on top of the like a tower when you are in possibly at your home or a mall, kind of experiencing the VR, etc. So it does that. So how does this work with pain management? Because I've seen some experiences where a kid wears this VR headset and the doctor gives the child the injection. The child doesn't even know about it. So how does this actually work? And maybe it will be great if you can share some of your success stories in this pain management with XR.
Sure. Okay, let's look at it all the way from the top. When I'm a pain management specialist, I've spent a lot of my life thinking about pain. Every day I go into clinic, I see patients who live in chronic pain. And across the world, this is a huge burden. I'd argue in one of the top 3 reasons why patients ever see a doctor is usually for pain. It's 1 in 5 Americans lives in chronic pain. So what we're talking about, the burden of what we're talking about is huge. I think when it comes to understanding what pain is, there are sort of 2 things that people talk about, right? There is the signal that comes to the body, to the brain. And there's a way that the brain interprets that signal and references its understanding of the body. So we call that pain. Both parts of the track, the signal going to the brain and the way the brain interprets that signal and sends it back down to the body. Most people think of pain as just the signal going from the body to the brain. But all pain exists in the brain. And the way that people experience it is different from person to person, from culture to culture. And what we found is that in the largest sense of it, virtual reality can help modify those signals, both the signal going from the body to the brain, but arguably and more importantly, the way the brain understands that signal. And so I'll give you a couple of examples. There's a disorder called CRPS, chronic regional pain syndrome. It usually happens after someone's had major trauma to a limb or a nerve. You have a skiing accident, you have a motor vehicle accident, you have your arm crushed. That can lead to sort of devastating consequences down the line where people develop a never-ending signal that comes from the arm to the brain. And what we've also found is that the way the brain evolves over time because of that signal changes the secondary part of that tract as well. So the body has a very distorted sense of how the limb exists. The way that I often see how this manifests is patients will come to me and they'll say, look at the difference between my 2 arms. One arm is way more swollen than the other. And sometimes that's true, and sometimes that's imperceivable. It doesn't mean that the brain is not interpreting that signal correctly, but it does mean that it's also distorting that signal. And one thing that we've seen that's very exciting, done by groups like Owen Williamson out of Australia, is when you take that person's mind who has CRPS and put it into a virtual body where it doesn't have that same connection to the arm, you can modify the way the brain looks at that signal. So people can have a reorientation of that initial distortion. They can see their arm kind of coming back to the right size. And in a certain percentage of patients, their pain goes away. And that's kind of incredible to us, because that therapy, that extended reality therapy, comes with very few side effects, right? We can give medications to change the way the signal works, or we can change the way the brain interprets that signal itself. So we call that version of how extended reality therapy goes embodiment therapy. But there are way more mechanisms of actions. In one mechanism of action, we can do things like help with acute pain. So the example that you suggested or you gave earlier about the child, that's something that we see happen fairly often. In the hospitalized setting, sometimes we use anesthesia to be able to calm a child down so we can do something like place an IV. But there's a lot of literature coming out that shows that the extended reality headset can cause such a profound level of distraction that the child can get the IV without the anesthetic. So think about it like that. Like we would give less anesthesia to a child to be able to do the same task. That means less risk. And usually that helps improve the quality of care that we provide. And those are exactly the kind of papers that we're publishing through the Journal of Medical Extended Reality. We want to see all this great stuff people are doing with things like embodiment therapy or with things like distraction-based therapy for kids, and make it known around the world. So that way, another thing to think about it is anesthesiologists, I'll just say right off the bat as one, we're not a very cheap, service to provide. Clinics around the globe, hospitals around the globe struggle to get anesthesiologists. If we're saying that the headset, which costs a couple of $100 maybe, is helping reduce the need for some of the anesthesia services we provide, that's great for hospital systems around the world as well.
But doctor, do you have insights on how are these virtual worlds doing this, where it kind of distracts the patient? I mean, because and when you mentioned about CRPS, what are the other areas? You're talking about like serious chronic pain. You're saying at this with extended reality, you can kind of help in the pain management. Maybe elaborate on that and how does this work? Because these virtual reality even now, I mean, are still like, when you experience them, these are not really photorealistic. That the experience is possibly like, it's not really realistic. I mean, though that, with like Unreal Engine and all, we are now pushing the boundaries of photorealism, but we're still not there. What headsets are you using? And how does this brain kind of get tricked into, believing that there's no pain? How does it work? Can you elaborate on this?
Yeah, sure. I mean, I'll be quite honest with you, Eddie. We're still learning a lot, right? We still don't have the deepest level of understanding of the mechanism of action, but there's certain principles, right? One of the principles is that you don't need things to be super photorealistic for you to have that effect, right? For the brain to undergo neuroplastic changes. And take, for example, the one that you gave not too long ago, the Ritchie's plank experience, right? Or riding on a roller coaster in extended reality. You would go so far as to say, I know I'm not on a roller coaster. But when that experience is placed in front of you, a lot can change. And what I often tell people who are developing these technologies is don't focus on perfect. The brain handles B+ great. And one of the things that we often see is that for patients who have very severe pain disorders, they have the ability to undergo rewiring of the brain, because we see it even with therapies like meditation and mindfulness and acupuncture. So what we've seen about the human brain is that it's highly resilient. And what I tell patients is that your brain wants to change. It wants to be able to outgrow this pain. And extended reality just pushes it in the right direction. It's a tool in the toolbox. But I think even if you take away Unreal Engine 5 or 6 or whatever is coming out, we don't make it photorealistic, it's still pretty incredible. And it still does access the same sort of neuronal wiring that can help bring patients relief. And that, I think, has been really helpful for my patients. We also find that the effect is much longer lasting than just the session in the headset. And that is also kind of incredible. So, for example, we have a group here in the United States that recently got FDA approval for their extended reality pain therapy, not just for something very serious like CRPS, but believe it or not, for chronic low back pain, one of the simplest conditions that we see in the pain clinic. I mean, millions of patients around the globe suffer from low back pain. At a certain age, we all kind of experience some element of that. And what they found was that sessions done in a headset over a course of a few weeks resulted in pain relief that lasts for months and months after. And that's kind of incredible too. That is another example of how brains have this sort of natural gift for this rewiring. And extended reality allows us to do that. Wow. Their sessions involve things like physical therapy. It involves things like mindfulness and meditation. And that can be exceedingly powerful.
Very, very interesting. So you mentioned CRPS and lower back pain. What are the other areas where XR and AI is being used?
Sure. So one area that we're also seeing a lot of development in, and I would argue that sort of the founders of medical extended reality therapy, like Walter Greenleaf, Hunter Hoffman, Skip Rizzo, really looked at it from the lens of psychology. So mental health, PTSD, depression, anxiety, phobias. You mentioned, a very common phobia of fear of heights. Extended reality offered people the opportunity to really come face to face with some of their fears and be exposed to them in an environment that they could learn to adapt to those fears without being in true physical danger. Actually, there's one of the founders of medical extended reality is a close colleague of ours here at Weill Cornell. Her name is Joanne DeFede, and some of their initial work looked at combat trauma from the Iraq War. That's an incredible, benefit to veterans to be able to have access to these kinds of therapies. And a lot of folks within our Veterans Affairs systems are now exploring this as a therapy that we should be able to offer to all veterans. So not just for pain, but we can also think of a lot of different use cases in mental health.
Yeah, and I think tech stack is completely converging. It's not just XR, it's AI, it's with neurotech and BCI and stuff like that. I think once it kind of converges, there will be more real world values over there. You are part of Extended Reality and Anesthesiology Immersion Lab. Can you talk about the inspiration behind its creation?
When I became an attending at York-Presbyterian Weill Cornell, when I became a teacher of residents and fellows, I realized we couldn't just keep this a small thing. We had to expand this. We had to really explore the pedagogy. We had to get evidence of how this is working out. We had to build more content. We had to build more lessons. And we needed to be the shining example of how education could be. And that really started us on the XRAIL lab. So we started developing lessons. We started teaching residents. We started developing N of 1 type of models for patient care. And we began learning a ton. We also realized that, like you said, XR and AI is converging. So probably around a year and a half ago, we had this idea that said, that was basically around the notion of not just hard skills training, with procedures, But what if we could train people in what some people call soft skills, but I also think of them as power skills, right? Communication. What we often see and what patients tell me all the time, those who live in chronic pain, is that they have a really tough time communicating with healthcare professionals. Because when healthcare professionals can't see the pain or it's chronic and somebody comes to you and says, I'm in 10 out of 10 pain, but they don't look like their arm has been cut off, people stop believing them. And this is something really sort of sad that the chronic pain community sees all the time, which is this notion that people don't believe their pain. And my colleague, Dr. Rubin, who works with me at XRAIL, and I thought to ourselves, what if we could use AI to create a conversational agent that lives its life in chronic pain? Would this help our providers, our trainees, better understand chronic pain if they could ask an AI any question that they wanted to ask? And so we built an XR+AI collaborative model called CARL. And CARL stands for Conversational Agent Relief Learning in Pain Medicine. We wanted to call it Carl Ippum, but Carl Ippum kind of sounded weird, so we left it at CARL. CARL is a 36-year-old male who lives its life in chronic pain. We trained CARL on, experiences and stories of patients who live in chronic pain. So CARL is not ChatGPT. CARL is a trained model that lives in hierarchies above ChatGPT. Unlike ChatGPT, CARL has a personality. Unlike ChatGPT, CARL has an embodiment of memories beyond what we've trained it on. So there'll be times where I ask CARL a question that has nothing to do with anything we've ever talked to CARL about. And CARL, through its understanding is a tough word when you talk about generative AI, but through its, let's just be technical about it, through its tokenization and training data on chronic pain, develops a narrative that is consistent with what I hear from patients every single day. So CARL hates when you tell it, CARL, you sound depressed. Maybe you should go see a psychiatrist. CARL will say, well, that makes me believe that you think the pain is in my brain and not real, which is something we see with chronic pain patients all the time, that sometimes their pain can be invalidated and people think it's purely a mental health issue. Surely there is a mental health component to chronic pain, but it does not help when a patient's in pain for you to say, maybe you should talk about it with a psychiatrist. And by the way, the psychiatrists tend not to like that either. So CARL has helped us train the next generation of physicians and residents and pain doctors through chronic pain by being a kind of coach. And when you wear the headset and you talk to CARL, Eddie, it feels more real than me talking to you right now on a Zoom chat.
Super interesting. Doctor, how has been the patient's response? I mean, how open are they to, something like virtual reality, because these headsets, even now, they are a little bulky. So how open are they? Like, what are the challenges of, implementing XR and AI in healthcare?
Yeah. Well, we should talk about the biggest one, which is who pays for it, right? XR is a new technology. We're just beginning to have good evidence that it's helping patients. And in my opinion, it actually makes the cost of our care cheaper. But that doesn't mean that the system has caught up to our way of thinking. Right. And this is something that we see all the time, not just in the United States and other countries too, but definitely in the United States, that we will have great ideas in healthcare. And it will take us 20 years for that idea to make it to the patient. I really hope it doesn't take 20 years for XR to make it to patients. And hopefully with the recent FDA approvals and health insurance companies and the government looking at this, we will make quick traction on this. But that's always the first question. Who pays for it? I think patients are open to the idea, but first they want to know, how much does it cost? Does their insurance company cover it? What are the outcomes like? And you're right. How comfortable is it? Now, I have noticed with my own patient population that they are actually very willing to try it because it's a therapy that can theoretically come to them, right? They can theoretically purchase a headset, they can theoretically do the physical therapy from home. And this is actually something that I think is a great value to patients, because patients often really struggle with making to appointments. Like, imagine, Eddie, you had CRPS. Let's just imagine for a second you had to live through this experience and you're trying to live your life. You have a full-time job, but I tell you, Eddie, you need to go to physical therapy 3 to 4 times a week for an hour. You're going to struggle with that. Anybody would struggle with that. You're going to say, how is work going to give me off this time, and how am I going to make sense of it? And in extended reality, like if I said, hey, instead, why don't you just get this headset, try out this therapy from home? You may be more likely to say yes to something like that and try and explore that. And, I've had patients expand all ages and try extended reality therapy. People need guidance. So it requires a level of coaching. But I don't think that will be what holds extended reality therapy up. I believe in our ability to be able to offer this as a real therapy for patients, because maybe 15 years ago, it would be hard pressed to find a 90-year-old who knew how to use a cell phone and knew how to use a mobile phone. And now we have patients downloading apps at all ages. So human behavior will change. We will figure it out as a society. But it does need a little bit of push, and it does need advocates. And we have seen in the literature that we've recently published on extended reality, one really great element of this is extended reality therapies often help bridge the gap between underserved populations and populations that often have natural advantages. So what this means is that we see that issues like transportation, wage deficits, access to therapy, these things are actually improved with extended reality therapy because they help cover the gaps that underserved populations often feel. So I'm really excited for what this could mean for patients. And I have seen my patients do really well with this therapy.
Right. Yeah, I think the future of healthcare looks super fantastic. I mean, my son goes to an online school, and there was a time when he used to go to like a physical school, and that means go to take a bus, wake up early in the morning, and then, the traffic is there, you get stuck for an hour, you reach the school takes around 6 hours, and then you come back with the same traffic, and you're completely drained, So I think with these tech stack, instead of us going to the education or the healthcare or the workplace, the workplace or the healthcare will come home. And I think that dynamic, once it kind of shifts, I think it'll just kind of change, upend the healthcare system completely. Doctor, what comes next for you? And would you be able to kind of paint a picture of what the future of healthcare is going to look like in the next 10 years?
Yeah, that's such a question. What does I venture to say that I'm very hopeful that healthcare, at the very least, looks different in 10 years than it does today, right? Because, as I mentioned before, there's a lot of resistance in healthcare to change. One of the things that I'm very hopeful for is that, first and foremost, more physicians across the country, more researchers across the country will continue to do great research with extended reality, that we're going to dive deeper into embodiment therapy, like I mentioned before, that we're going to do more big clinical trials for common conditions like chronic low back pain. I'm very hopeful that people will start to produce real data that shows that patients are getting better with extended reality therapies. I'm also hopeful that medical schools across the world will look to collaborate in extended reality. Right now, I'm sitting here in New York. My ability to teach a class for, say, a new procedure that we're doing here in New York to, say, the people, to medical schools in places like Asia is very limited, right? But can we imagine a world that maybe in 10 years' time, students today wear your headsets. Dr. Jotwani is coming in from New York to, teach this procedure, or vice versa, that I am wearing the headset and somebody from India is going to be teaching me how to do a procedure that I don't know how to do. I think, that future is really exciting for me, because that means that patients are going to start to see revolutionary changes in how we practice medicine. Going back to what I said earlier, 20 years to make a big change in medicine. right now, say there's a new procedure out there I don't know how to do. I'm going to wait 6 months to go to a conference and learn from the people at the conference. I'm going to get, hopefully that patient, to get that procedure, I hope in maybe a year. But that patient is suffering for a whole year while I learn how to do something. And it shouldn't be like that. Maybe extended reality in the next 10 years is going to change that and how we train each other and how we get better at medicine. And lastly, my hope is that the systems in general, right, like our healthcare system, will recognize this and will start to value it. We'll start to incorporate it into care pathways, right? Because we can have these great ideas and the tech stack can become incredible. But if, again, nobody's paying for it and it's not integrated and operationalized, sometimes the greatest technology in the world can go nowhere. And it's going to be the mission of myself, for the American Medical Extended Reality Association, for the journal that we run, the Journal of Medical Extended Reality, and for labs like XRAIL to make sure that that doesn't happen. Because we're seeing great outcomes with extended reality, and we want to make sure that this actually makes it to everyone.
Right. Doctor, really appreciate you taking time and being part of the podcast. I think we sitting in such a fantastic point of time in human history. And you rightfully pointed out, I think, we need the system to change. Once the system change, then all of these new things can seep in and completely upend how we do healthcare. And I'm sure it's a matter of time, because it starts with, I think, leaders in the space such as yourself, the advocators, the evangelists of, these tech stack. And once I think the larger population gets to know the immense impact of it, I'm sure it's gonna disseminate like really like a wildfire. And so I hope and I wish that those patients who are like living in pain around the world get access to this treatment therapy that you have with XR. So more power to you and your team, and to my listeners. If you like what you see in here, then please press the subscribe button. And until next time, see you guys. Bye-bye. Thank you. Thank you, Doctor. Really appreciate this. Thank you.
Wonderful.